Kia ora. It's really a privilege to talk to you today about my research. I'm not as far advanced as most of the others, so I have initial findings, and I'm more going to talk about my story today. And I just want, before I start, to really acknowledge my two supervisors at university, Professor Claire Hocking and Dr. Gail Mearns. Without them, I wouldn't have been able to do anything. So just to give a little bit of background, I think we all know how challenged we are today with increasing demand for health services, and how we really struggle to either get people to access health services, to stay well at home, like Mari has just given us some explanation. So a few years ago, I got involved with working alongside the Pacifica team with the Whānau Ola Advocates, it's just a different name for the assistants. And one of the assistants had to gain her social work registration, and she approached me to help her with the work, and she had to do a case study. And I was just blown away by the way they were working and the model of care they were delivering. It was quite a new change for them as well. They were previously cultural support workers working only on the wards, and they were retrained and reskilled, and they were then developed this Whānau Ola Advocates working with patients. And I just thought this is a model that probably for social work could really, it's applicable to how we deliver services. But social workers were really quite anti any assistance, and at the same time we were working in the community with looking at a different workforce, how we work differently with assistants, and what are the tasks that maybe another professional or assistant might be able to do instead of only a regulated professional. So the social workers, of course, said, no, there's no way they're going to work with assistants. They've never done this before. Or they could only think of really menial tasks that an assistant will be useful for them in their service. So that's why I decided when I approached my doctoral study that this is really an area that I would like to explore more. So I've chosen a qualitative study with a grounded theory. And like Strauss and Corbin said, defined it, it's a qualitative research method that uses a systematic set of procedures to develop an inductively derived grounded theory about a phenomenon. Sounds quite easy. And I've chosen a Charmaz approach, and the difference in the approach is really that Charmaz is has a more, let me just see the second one. Other grounded theorists will look at the theory will emerge through the data, and Charmaz is looking at how participants construct their data and their social experiences, and how the researcher is actually co-constructing the theory with the participants. So it's quite involved. So this is just a colorful picture of the wonderful stuff that I'm working with to just make it a bit less boring. But it's just all the processes that happen simultaneously while you're collecting data, you're analyzing, you're coding, you're going back to your data, and you're writing your memos to explain your theoretical processes. It's quite an interesting journey, and I'm not going to read all of it. You're welcome to have the slides. So I've done one-on-one interviews with the whole Whānau Ola team that existed at that time, with all the advocates, the social workers, and the manager. And I've been coding the transcripts. I'm busy with a constant comparison with the codes and the transcripts. I'm looking at the categories. I haven't got a core category already, but what I see, I will explain to you just in a minute. What is it, the information that I get? And then at the end, we do the literature review, so I haven't got that done now. Sorry, so what I've said, in the literature that I looked at when I did my research proposal, it was quite clear that what I've heard from my social workers is not different from what happened elsewhere in other professions in other parts of the world. They all said, we're going to lose our jobs. Who's going to do our wonderful work? We know what we're doing. We don't want assistants to work with us. But there's also, we need to look at our alternative workforce. And it's nothing new in health to work with assistants. We have rehab assistants. The dietitians have assistants that do nutrition screening, so it's quite a familiar concept, but for social workers, it's not that familiar. And I found in my initial research, the literature research. There was only one pilot study done in Queensland with a social work team in an inpatient hospital setting where they actually found it was really helpful having assistance after getting through all the barriers and the myths about having social work assistants. They work really well, and they could actually free up some of their professional time to be doing their supportive counselling and work with complex family issues and violence issues that were really their core role. So, but apart from that, there wasn't any other thing published about social work health assistance. So my preliminary findings was really what I want to talk about today, is that I found really with this Whānau Ola advocates and the engaging with families, the absolute wonderful, deep cultural connections that they could make with the families that they work with. So they were paired up with the same culture as themselves. So they will, if they're from Tongan descent, they will work with the Tongan family. So once patient, and they work with patients who come in with multiple chronic conditions, complex conditions, maybe coming back to hospital the second or the third time in the last 12 months. So they will engage with them on the ward, follow them back home, get their consent, follow them back home, get to know the family and whoever else is in the household really well, make the connection with the spokesperson in the house, and then just make sure everything happens for the family. And what they say, the participants, is we assume people know, but they really don't know. And I don't think we always realize how complex our health system, any health system, is for people to really navigate. We find it difficult sometimes. So they could really build the bridges and close the gaps for families to just re-engage them with their GPs to make sure they access the services in the community. They have to learn what's out there in the community to be able to engage the families. But the interesting thing also was the clear boundaries that they just had working with the social workers. They were really clear where their part of the role ends and where the social workers should be involved. So what will happen then if there's really, and they also have case reviews with the social workers every week, so they will go and do the social assessment, come back to the social worker, do a whole review, look at the intervention plan. So they work under close supervision of the social workers. So, and then if it's necessary for a social worker to be involved or any other professional, they will go with the assistant. They will never just turn up at the family's home by themselves. The assistant is the conduit for all of this to happen. So that's where the trust in the relationship lies. So there's really clear accountability from both sides. And I mean, they had targets to meet. They had to document. They had to, have a lot of administration work to be done as well. A caseload to manage. So hopefully my recommendations would be, my dream is to actually replicate this in another service as well, or in the community, just have a start. And since I've been talking to social workers about this and how just demystify some of the boundaries or concerns, there's really been some interest, and hopefully we can engage better and walk with families in a better way.